It's a real pleasure, and thank you very much to the Safeguarding Board for asking me to come and talk to you about frailty. Something, just as a word and as a concept, probably doesn't land terribly well with people, but a really important concept to try and explain to you, and why we are getting particularly interested and excited about this at NHS England at the moment. I have quite a lot of slides which are in your pack, and I won't go through most of them in detail. There are one or two key things that I want to try and impress upon you and persuade you of why this is an important area of concern to us as a nation and as people. So just to start off, this is really what I want to achieve. A national clinical director doesn't have any great power. We don't have budgets, and well, I don't certainly, but we do have influence. My key objective is to try and influence people to think much more carefully about what they should do as people, as professionals, as individuals, as people in the street, when they're greeted with somebody who may exhibit physical frailty. I'll explain what I mean by that in a moment, and cognitive disorder. And if they have both together, that can be a particularly difficult combination for the person who we're looking at the time. So if I do nothing else today, I want to persuade you of the importance of recognising what is in front of you when you meet somebody with these conditions. I just want to quickly go through why this is now so important. And we all know about the ageing population. I entered medicine back in the 1980s. I went to medical school, and that was one of my first lectures. We were told then that the ageing population was going to be something to occupy us during the course of our careers. But what I want to do is just draw attention to the detail in this, because this is about numbers. These are individual people, and the overall numbers of people who are reaching a great age in life are larger than ever before. In many ways, that's a success story. That is about, for many people, successful aging. If you're born in 1911, your chances of making it to 90 were very slim. If you're born in 2011, your chances of making it to 90 are extremely good, almost certain. So these are successes of a healthcare system which has organised itself to manage disease and long-term conditions right the way through the biological life course, maximising people's opportunity to live their lives. So that's a good thing. There is a cost to pay for this, and the cost is that we're seeing at the moment, unfortunately, not just people living longer, but also greater numbers of people living longer with lost function, with disability. And that presents us with some difficulty. One of my ambitions is therefore not just to compress disease into the last few weeks and months of life, but also to push back the boundaries of lost function, to keep people as active and as healthy throughout their entire life course as possible. And that presents us with a significant challenge. The way that we're addressing that is to get upstream of when those things might happen to people. This is all about prevention. In particular, at the moment, the part of the population that we're most concerned about is those who are aged 85 and above. If you look at the World Health Organization definition of an older person, it's somebody aged 41 and above. So that probably covers a few of us, certainly me, in this room. But in this country and across Europe and developed countries, we're particularly concerned about meeting the needs of and identifying the needs of people who are in their 80s and above. Because those people, by absolute numbers, are expanding rapidly. Oops. This is where it skips through the next 10 slides in one go. Am I zapping the wrong thing? Yeah. So we've got absolute numbers. When I entered my job at NHS England 18 months ago, I was worried about 10 million people. By the time I finish my career, there will be 12, 13 million people aged 65 and above. Many of those people will have multiple long-term conditions. These are health conditions that cause some impact for some. You may wish to count up your own number of long-term conditions. As you get older, you tend to collect them somewhat like bad habits. In many cases, we are now converting diseases that used to end your life into long-term conditions. Cancer is a good example. Many people have survived cancer and are now living with and beyond the treatment for their cancer, but also having to deal with some of the consequences of that. Some of this, not all of it, is driving increased attendance into hospitals. And one of the things that we're particularly concerned about right now is how this is going to impact upon hospitals and the flow through hospital care, particularly for people with increased complexity, many long-term conditions all at the same time, some of which may or may not be causing some difficulty for that individual, some of which may just be sitting there in the background. I think there's a satellite delay on here, isn't there? There we go. Now, frailty is something that I'll explain in a moment, but just be aware of the wider context of this. And these are some slides. I'd strongly recommend a report written by my colleague James Nasri, who's a social scientist based at Manchester University, called the Golden Generation ? If you Google that, you will find a very interesting report which sets out some of the wider issues that select people in the population who are particularly vulnerable to the effects of ageing but not ageing well. And what he's demonstrated very eloquently is that those people who are in the lowest quartile of the wealth population not only age earlier in a poor way, but also more rapidly. So the effects of their conditions are much more impactful upon them. For the richer quartile of the population, they always do much better. And this is driving, in part, some of our health inequalities in this country. On the right, as you get older, this is something for those of us who haven't quite reached the middle of this slide, which is the 7th decade. As you get older, you actually get happier. And then you start to become a bit sadder after the 7th decade. The poorer people in the population never quite achieve the same levels of happiness and well-being as the richer people in the population. And that has significant impacts. It means that some of those people are left disenfranchised from society. And I think one of the most important things that sticks in my mind is that loneliness, which is linked to low mood, loss of well-being, and anxiety and depression, all of those things have the same impact on an individual as smoking 15 cigarettes per day. I was talking to Alistair Burns, National Clinical Director for Dementia Care and Mental Health for Older People, a few days ago. The impact of having dementia is the equivalent of smoking 200 cigarettes per day. So these are impactful conditions on people's future life expectancy, not just their ability to maintain themselves within society. So what's the NHS doing about this? We have a thing called the Forward View. It's just been refreshed and we've now got some priorities. These are very much driven by public consultation, and the key thing at the top of that is maintaining the urgent and emergency care system. I don't think anybody would want to really argue with some of the priorities that are on this slide. But throughout and in the centre of all of this are older people and adults with complex needs. As I say, an older person can actually be somebody from the age of 40 onwards. In my own city, people we know physically age much more quickly in some parts of the city than others, so that life expectancy in the north part of the city is up to 10 years less than in the south part of the city. We've seen improvements in healthcare efficiency and acute care. The reduction in bed numbers is partly as a result of the increasing technologies that we've seen delivering healthcare in our NHS over the last few decades. But there is a limit to what can be achieved in terms of bed reduction. One impact of this is that a lot more care is now delivered in community settings outside of hospital than ever before. And I think one of the things that will hopefully unite us all here is the need to ensure that all of those people are kept firmly in view. So what do I mean by frailty? And I'm going to use this as a technical term. It does raise, as I say, some irritation for some. We've taken wide consultation about this. Like many geriatricians, we are saddled with terms that don't necessarily sit comfortably and sometimes are used as terms of derision. But actually, we mean something very specific by frailty. We mean the accumulation of health deficits over a period of time, such that that person's resilience is impaired and their ability to withstand even a minor health insult, such as a trip, a fall, a minor illness, such as a urinary infection, means that they get sudden and catastrophic decompensation. Sometimes that creeps up on people without them being aware of it, and their levels of dependency suddenly increase with uncertain recovery, which is often prolonged and sometimes incomplete. Knowing about that before it happens gives us an opportunity to either prevent those sudden decompensations or to more assertively manage them from a health point of view and then from a care and support point of view after that event has occurred, to maximise that person's opportunity for recovery and back to independence. If we don't know about it before it happens, we will not be able to intervene in a timely way. How common is it? This is from the English Longitudinal Study on Ageing, ELSA, and we know that it's in its most severe form demonstrated by people who are suffering difficulties with walking, getting about, who may have lost some functional ability. The impacts of frailty are that you lose muscle strength and muscle bulk. It's more common in women, but it only affects 1 in 7 people over the age of 60. There are ways of getting to those individuals that we're now putting into the healthcare system, because we feel that if we can identify those people early, remember I have 10 to 12 million people to worry about, and we can't go and review 10 to 12 million people individually to identify this. What's multimorbidity? That's the presence of 2 or more long-term conditions. Whilst it's linked to frailty, it's not entirely the same thing. And lost function is also not entirely the same thing. So not all old people are frail, not all frail people are old, not all people with frailty have multiple long-term conditions, and not all people with frailty have lost function to the point where it's obvious. So these are distinct groups that we're looking at. But what we do know is if you look at populations of people who exhibit frailty by varying degree, compared to somebody who is at the same age who doesn't exhibit this condition, they are much more vulnerable to poor outcomes, particularly death, entering the care system, particularly care homes, and utilising the urgent care system, hospitals, in an unplanned way. If you have severe frailty, that magnifies your risk compared with somebody exactly the same age as you by 5 times of death in that year. If you have mild frailty, which may not be immediately apparent, it doubles your risk in year of dying using hospital care, entering a care home. So what we've done about this is we've agreed with general practitioners in this country to start finding this in a routine way, routine frailty identification, which we can then put into people's healthcare records and create a new currency of a condition around the system which enables us to identify people in a timely fashion. This is very early stages to this, but it's really important to do. And in fact, the first country in the world to do this in a systematic way for the entire population. So this year we had put into the general practice contract a recommendation to routinely screen for frailty and, where possible, to identify different degrees of frailty. In particular, we're interested in severe frailty. As I say, these are not always people who are known to us, and to check those individuals. The important thing about the tool that we're recommending, it works from the electronic healthcare record data that we have in all of our health records now. So when you visit your GP, they will code things that are occurring with you, and that information can then be assembled into a number of deficits in your health, which when they reach a certain threshold will select you out as being in one of those populations of risk with mild, moderate or severe frailty. What we're asking GPs to do is then to verify that against the individual that's in front of them, and to do a couple of things. There are many more things that we could ask for, but at this stage we've gone after the most important. The first is to identify whether that person is at risk of falling, because falling is common, particularly in people exhibiting frailty. It's catastrophically bad for you. It can lead to death prematurely. It can certainly lead to loss of function, loss of confidence, and people often then become more vulnerable to other things that they would not wish to happen to them. So identifying falls risk and doing something about it. What do you do about falling? You minimise the number of medications which might predispose you to falling. You check the safety of the home environment for falls and trip hazards, and you, where possible and the person is agreeable, get them involved in strength and balance training. We can all do this, in fact. And by doing that, it significantly reduces your risk of having a fall in the future. This has been done systematically in some countries. We're not yet doing it in this country. Medication reviews is important, increasing number of medications. I think mostly now we're recognising that whilst many of these things are good for you, in some cases they are also not necessarily in combination as good as we might think. And so there is nice recommendation now that we look at people of key interest who may exhibit multiple long-term conditions, multimorbidity, and rationalise their medications so that it's tailored to suit their particular needs, what they want, rather than what guidelines tell us to do to people. This is very much more about personalising their care to them. That requires us to have a direct conversation. So, how do you know whether somebody's got frailty? There are several ways that you can do that. You might want to test yourself out on these. So these are all validated tools. They're in your pack. Prisma 7, or you might want to, even better, go and talk to somebody that you know, who is a friend, neighbour, somebody in your care, somebody with who you have professional contact. What that does is it directs you towards the need for further, more detailed assessment. There are easier ways. Whoops. You can test your gait speed. So I do this in my own clinic. If you can't walk at 0.8 metres per second, which sounds like a bit of an ask, but try it, then you may be exhibiting the frailty condition, and you should probably go and get yourself further assessed. The same thing if timed up and go. These are all validated tools. There are many other ways of doing this, but we're recommending these because they're quick and easy to do. You can also look at the person in front of you, and in hospitals we're increasingly recommending the use of this as a quick identifier. It was developed by probably one of the world authorities on frailty, Ken Rockwood, who's based in Canada, and validated as a means of categorising people's level of frailty that you can then do. And this takes about 40 seconds to match somebody, the person in front of you, against the degree of frailty that you are aware of them having. What we don't know for individuals is that whilst we know populations progress relentlessly with frailty, it is entirely possible that somebody with moderate frailty can actually become fit again by treating one or two things to do with them. And there are many modifiable factors such as good foot care, good eye care, things that you can do around their environment, strength and balance training, which might modify that person's status and move them up into a fit category from being more at risk. What we do know is that for populations who are losing resilience, there is an increasing need for care and support planning. And because frailty at population level increases in severity as you age, once it's started, we have a number of opportunities. One is to try and identify people who are still fit, So healthy and active ageing is a key part of NHS England's agenda, and it's also a key part of Public Health England's agenda. Once it's started to develop, slowing that progression down wherever we can by assertively supporting people to live well. And I was particularly struck by Jerry's comments about keeping the mind healthy and active. Keeping the mind and the body healthy and active is also, your body's still active, so yeah. We'll test your gait speed later. But these are things that you can do to enable people to remain productive and involved in their own social activities in their own community. We should all be doing this, by the way. And this is something that progresses right the way through to the end of life. So this creates a new paradigm. And we're now in the right hand of this slide. So previously we talked about the frail, elderly, defunctioned people. That's this phrase that I want to see banished from the lexicon of health language. It's a label, it's not particularly helpful, and it casts somebody out as defunctioned irreversibly. What we're moving towards is people who are older, age 41 and above, who are living with frailty, about which we're providing support, care, planning, helpful advice to maintain healthy ageing, but where that level of function is starting to impact upon their lives, finding other ways of supporting them to plan ahead. And recurrent care planning is a really key part of this, something which sits, I think, very comfortably with colleagues involved in safeguarding. So these are things that you can do to modify, and there are many others, but these are just a list of things that you can do to modify frailty in an individual. I've not emphasised alcohol and smoking because we drum on about that endlessly, but it does actually stop you ageing in a bad way. Enables you to live longer. Just want to talk very briefly about this. Comprehensive geriatric assessment. So it is comprehensive. It's not geriatric as such. It's not a great term. As I say, I went into geriatric medicine knowing full well that I was going to be saddled with a term that most people think is not particularly complimentary, either about me or about anybody else. But nevertheless, that's the term we have. It's not also just an assessment. It's an intervention. And what it does is it improves people's outcomes. So if you do it well, and cover the key domains of interest, and it's multidisciplinary. It requires you to have a lot of other people involved, a 360-degree holistic assessment of that person's needs and intentions in life. Then you can make a plan. That's the outcome of this process for care, which might involve things to do with their health, their social care, their community, their environment, etc. What we know when done well, particularly in a hospital setting, is it reduces your mortality, it reduces your risk of entering the care system permanently, and it reduces your propensity to lose function. And that's based on good scientific evidence recurrently. This has just been reviewed again this year and still remains the case. It's an effective tool. That's the gold standard. It's set out in something called Fit for Frailty, which I would strongly recommend you to have a quick look at. It's in the British Geriatric Society's website. One of the key recommendations in that is that you start right at the top in that bubble, is to recognise frailty. You cannot manage a condition unless you recognise it first. The only thing I would point out in this is that the way that we're recognising frailty doesn't yet fully encompass mental health needs, in particular depression and anxiety, which we know to be common in older people, is often unrecognised at the moment. And Alistair Burns and I have been putting a lot of emphasis on the need to think about and manage mental health disorders in older people, because they are treatable and reversible, and in fact older people respond better to treatment for their depression and anxiety. If you treat the depression, as Alistair says, you get the anxiety for free. Key ingredients of a good comprehensive geriatric assessment. This is all based on the scientific literature. I won't go through the detail of this, but effectively it's a multidisciplinary activity, and if you do it recurrently, it works. If you link it to frailty, It also enables you to, particularly in a hospital setting, select out the people who are most likely to survive that hospital episode and therefore can be discharged early. It also indicates those people who are most likely to die during that hospital episode unless you intervene. So it gives us an opportunity to stratify. If we do that by age, that's on the left, it doesn't separate out people very well. So if we use an age-related approach to identifying people's needs, it doesn't really help us. If we use the addition of a comprehensive assessment, it helps us to much better separate out people with different needs. Also, not surprisingly, if we then look at those individuals with complex needs who have got slow recovery, it will go there eventually, but what the slide will show you is that those people's length of stay in hospital is also separated out. So you can pick out very, very early the people who are most likely to stay in a hospital setting or extended care beyond hospital, but may well have additional needs. So you can find those people very early and much more assertively wrap the care around them at an early stage. These are the most vulnerable people. Unless you identify them early, they get swept into the hospital soup, for want of a better term, and aren't sub-selected out, so we don't concentrate on them until suddenly we start to notice that they're not passing through the process of healthcare that we would expect them to recover from. And I think this is the key concern that we have this winter. It's no secret, and it's in the press every day for a good reason. We are expecting the health and care system to be put under considerable strain this winter. This is something which I do not think is going to go away, and so we have to try to identify people who are the most vulnerable to poor outcomes, things that they do not wish to happen to them. Get those people early, identify them, assess them, and meet their needs. These are the people who are going to, I think, suffer the greatest impacts of a poorly flowing healthcare and social care system. And that's a team effort. It's about focusing on people's needs assertively. It's doing it 7 days of the week. And it's particularly about this thing of case mix. In other words, how much frailty does that person exhibit? How much is their condition going to be affected by that thing that we've not yet recognised in them? To give you an idea, somebody with severe frailty entering an acute hospital episode with an acute illness is at risk of dying. 20% of those people will die in that hospital episode. We find those people early, we can do something about it, even if that is end-of-life care. But it's very much about making sure that the survivors, the 80% who survive that episode in hospital, also have the best opportunity to recover. Now, I'm just going to go through, this is where I hope the clicker doesn't break down. You can see the outcome of this slide, but what we've done is we've built a healthcare system over the last 2 or 3 decades, which has hospitals and primary care and general practice somewhat interconnected, but not explicitly. And what we're trying to do here is to create a way of understanding people who are moving through the system in ways that aren't necessarily planned for them and not necessarily within their control, but maintains that common understanding so that when they do enter the system, we have a common understanding of their needs throughout, ways that we can interoperate that person's care needs without continuously reassessing, reinvestigating, reigniting, all of the things that doctors do. We love taking people to pieces and putting them back together again, but actually that's not always what's required when somebody isn't actually acutely unwell. We've engineered various bits of the system, most of this intuitively, some of it explicitly. Anybody here remember the National Service Framework for Older People? It's now well over 15 years old. We've invented some key chunks, but we don't know exactly how much of that we need. And we don't have some timescale set around how that operates. And I think importantly at the moment there is still a key divide between the primary and secondary care system, which by identifying people's needs, not the organisation within which they sit, we can have a common conversation that can be maintained during that person's journey in transit. Mostly people, of course, do not spend their time in hospital, but often we focus on that part of the system without necessarily paying too much attention to what might happen either side of that. I want to put in some standards around the way we do this. I want to make sure that we do things in a timely way, and I want to make sure that all parts of the system have a common understanding of this condition. And what that does is gives you a system that's fully accountable throughout. So we've talked about sustainability and transformation programs in the health service. There are 44 of these across the country. These are going to be accountable care systems as we move forwards, and they are accountable for the needs, meeting the needs of the people that I've been talking to you about. What we need to do is make sure we don't lose sight of them. Is it possible to simplify assessment? Short answer is no. I think do that at your peril, but you can do it quickly and effectively if you work together. And I think you can use frailty as a marker, as an identifier of people who are most vulnerable. What we're doing now, as I say, it's starting very much at the base level of this, thinking about 10 million people, finding those 1 in 7. We're routinely identifying frailty. We're putting it into people's health records. We're using that in an intentional way. It's not a negative label. It's a way of identifying people's vulnerability and ensuring that we're putting the right care around them at the right time. There's a lot of research going on in this area. The frailty research community have been operative for 30-odd years. It's extensive, and there is a lot of evidence behind this, but there's a whole lot more we need to know urgently. If you are interested, which I hope you are, we're currently at NHS England working out how much frailty actually costs the system. We're doing that because we want to know where it's being spent. Are we spending it on the right things? Are we investing in the right things as a healthcare system? We have to do this in a joined up way, which is why the partnerships that are necessary between agencies is not all about health, are incredibly important. And I think particularly for this conference, it's about safeguarding those who are most vulnerable. So having some standards in the system which enable us to do that consistently will, I think, be of key importance. And then the final thing, if you're interested, please go and look at the NHS England Long-Term Conditions website. We are doing a lot. If you want to know about the technicalities of the general practice contract, please go and have a look at that. And if you want to know any more about it, please email. There are actually people on the end of the email address at the top there. And if you want to track me down, there's my Twitter handle. This is my shameless attempt to increase my Twitter footprint to larger than Alistair Burns, which is in the tens of thousands, no doubt. Thank you very much.